we know that this patient is not growing. We know that elastics are not going to reposition their jaw from growth. Right? This patient, they're not growing. That's not why it's going to happen. But we know that sometimes the muscles can splint that patient into a poor position. You've got this massive problem, and you're essentially looking at this situation right now, and you're saying, I'm going to fix this, right? Like, this is what I'm going to do. I need to fix this problem, right? I've got a crossbite going on in my premolars. I've got an open bite in my anteriors. I've got crowding in my lowers. I need to fix this. How do I do it? So first of all, is expansion occurring? Are we developing this upper arch? Yeah, we are. Then the next thing here is, are we doing buccal root torque? Are we putting this in to the equation? So this patient comes into our practice and she's 25 years old. Her chief complaint is pretty straightforward. It's a classic one, right? I don't like the way my teeth look. Now, what do we see when we actually evaluate her bite? Well, she's got a crossbite. And what do we commonly see when a patient's got a crossbite? I always look to the gingiva in that area, and we have recession. I don't see any abfraction yet, but I see recession on all three of these posterior teeth that are lingually inclined, the two that are in crossbite, but also that first molar as well, which is super worn down because of the edge-to-edge bite. Obviously, her anterior teeth are crowded. Her canine's blocked out of the arch. So what tooth is the most pristine that has never done a day's work in its life? This canine. It's doing nothing. So if we can bring that tooth into the arch, well, congratulations, you will have just given her an extra tooth that she previously was not able to chew with, just straight on bringing that tooth into the mouth. We're about 50% deep bite in the anteriors. Again, her lateral incisor here, this lateral incisor has never done a day's work in its life either. When we look to her pan, we can see wisdom teeth are sitting at a pretty steep angle. Now, is this a significant concern for me? Well, I mean, yes, I would love to get those wisdom teeth out, but is it something that prohibits us from being able to do treatment at all? No. It just means that because this wisdom tooth is hitting against the second molar, the 1-7, it's challenging because you cannot put any distal root tip into this tooth if that wisdom tooth stays. And you'll see that at the end of treatment here. We don't take out her wisdom teeth because she doesn't want to do that. And she asks, can we treat her without? Yes, we can, but without being able to get the proper distal root tip, you're going to notice that the distal aspect of the 1-7 is not going to be fully down and in great occlusion because of how that wisdom tooth is hitting against it. In terms of crowding, well, we have some basic crowding on the lower, nothing crazy. But on the upper, we have quite a constricted arch. So here's my question to you, is that if we are looking at arch development in this situation, I want you just to look at this. You know nothing about teeth, let's say. But I show you this picture where you see lots of pink. And if I was to say to you, is there space, is there bone, is there gums, is there bony housing, so to speak, for these teeth to expand buccally? Now, I guess if you didn't know anything about teeth, it'd be pretty impressive if you knew what buccal meant. But if you just look at this, right, and you don't know anything about orthodontics, and we just said, hey, we want to move the teeth into this area here, is that the most concerning? No, right, because there's bone there, right? Even if we look at the first molar, there's lots of bone here. I don't need a CBCT to tell me that on the first molars. I can't see on the second molars. Good luck answering that. And on the other side, let's take a look. On the 5, that looks good. On the 4, less, but still some. On the 6, hard to see. But how do I evaluate in this circumstance then? Can we expand teeth into that position? And the answer to that is I look at it, I feel it. Yes, we have a CBCT, and if needed, I could take a CBCT to see what the bone situation looks like. But as a standard of practice, do we take a CBCT on every single patient? Well, I mean, it's always funny, depending on if you're lecturing in Europe or if you're in Australia or Canada or South America as to radiation guidelines, but it's very common to take a CBCT on every ortho patient in North America. That's not uncommon at all, orthodontist or general dentist. Now, we don't in our practice at this point, but at one point we did take a CBCT pretty much on everybody, and we'd be able to get full cross sections to see exactly how much bone there is. But do you need that? No, you don't. You absolutely do not, right? Because these patients, they are, you can feel it, you can look at it, you can palpate it, you can see it. So you don't need to specifically take a CBCT in order to see that information. Okay, anything else that's super remarkable about this case? I would say no, nothing in particular here that I'm not concerned about. But in reality, what are our goals? Well, it's straighten her front teeth. If you don't do that, she's going to be really pissed off when we fix everything, but we don't straighten her front teeth. In terms of the abfraction, well, we've got to expand those teeth and get her out of crossbite. Same thing with the first molars there. The second molars are not in crossbites, so it's better. And ideally, I'd love to get her wisdom teeth out, but that doesn't end up happening. In terms of her smile aesthetics, yeah, it's your classic situation. But let's go ahead and just take a quick evaluation then of the gums. Well, we see gums in the posterior on her upper right, and we see it in the anterior. When we compare the length of these central incisors, and maybe I'll actually jump to the ClinCheck now because this is where you're going to see it better. You notice that she has quite the difference in height when we look at her central incisors. And the reason why is because one tooth is more lingual than the others, just slightly. But when we look at that right central incisor compared to the lowers, well, it's doing more work. It's hitting first. And so the most buccal tooth on the lower, the most lingual tooth on the upper, those are the most damaged teeth. It will happen again and again and again. The pattern is the pattern is the pattern. You will see the exact same thing on every case for the rest of your life if you didn't know this already. The pattern is the pattern is the pattern. So in terms of our treatment plan, our ideal and our goals in this case is to say, hey, let's put the gum line in the right position. Right? If we can put the gum lines in the right position, well, then we've essentially undone the wear, so to speak. But the next consideration is we need to do restorative. So we have a conversation then with this patient about the restorative aspect of things too. The one comment that there is there right now is just we're trying to restore group function to stop the destruction. Well, group function is referring to either the excursions of the teeth so that the premolars are all hitting together. That would be group function. Whereas canine guidance would be specifically allowing the canines to be the last point of contact as that patient is sliding into their lateral excursions. In the anterior excursion, you can think of it as group in the sense that they're going to hit all of their anteriors as they come into that excursion, right? But that would be more of our incisor guidance, not so much group function. So group function is specifically referring to as they slide into lateral excursions, that they would actually be hitting all of their posterior teeth, premolars and molars, whereas if they're sliding with the canine being the main point of guidance, and that would be canine guidance. Those are both acceptable occlusions in this circumstance. What we really don't want to have is that they're specifically hitting just on one tooth that is not the canine. So a good statement would be, so it's a great question, if they are sliding into excursion, the only time they should ever hit just one tooth as they're functioning is in excursion when it is the canines that are functioning for that patient. Oh, by the way, guys, I just want you to know this. I'm not being paid by Align to tell you anything today. This is completely free. Align is not sponsoring this. So when I tell you that we utilize Invisalign and we use ClinCheck software because it's the best, that's my genuine opinion. Nobody is paying me to say any of this. I didn't put the disclosure at the beginning like I'm an independent consultant of Align or anything like that because I only lecture for Align usually 2 to 3 times a year. I'm going to lecture for them for global events and I'm going to lecture for them for big events like Summit. So everything that we teach dentists is through our clearly select education and our clearly aligned education. It's not sponsored. It's bringing you all of the organic thoughts that we have without any filter, without any bias, without anything any agenda. And again, I say this because I use exclusively Invisalign. At this point, I've used pretty much every single aligner company that's out there. I literally had aligners specifically mailed up to Canada that were only available in the States so that I could use those specific brands, like, for example, Candid. You might have heard if you're an airway specific doctor that Candid is all the rage about being airway centric. Well, I've done a dozen Candid cases and can compare and tell you that when you're looking at the software considerations of designing the case through Candid software compared to Invisalign software with ClinCheck Pro, there's a reason why we use Invisalign, and that's because we want to give the patients the best outcome. And what I care about the most isn't actually my lab cost. What I care about the most after treatment results is my chair time. Because my chair time is what costs me so much more money than anything else. Right? When we evaluate all these practices around North America, if you're in New York, you're paying about 400 US dollars per hour in your practice for chair time. Just to put the lights on and have a basic chair sitting there because your rent is so ridiculously expensive. I'm sure it's the same thing in Sydney and Melbourne and Brisbane. I mean, you guys are very centric in terms of your high density population. And so we're utilizing what's going to be the most effective for the chair time because I've crunched the numbers. We've done 3D printed aligners in our own practice. It matters more how effective we are with delivering the aligners and reducing the chair time. And it matters more about how much time are we spending designing these cases and doing them. Again, one mistake could cost you another series of aligners, which could take up another couple hours of chair time. So chair time is the most important number. I'm not going through a business lecture right now. I do have lots of business lectures where we jump into the analytics of cases and how to be the most profitable. But the goal for this right now is more so to focus, like we see in the title, it's biomechanics. So, okay. So what I'm actually going to do for this case to start with is I'm going to go back to ClinCheck number 1. So this is the very first ClinCheck. And what I will do when I'm designing and planning cases, now that we're jumping into this case to start making modifications and adjustments, is I will utilize a program that's called Text Expander. So this is my Text Expander. And so the way that Text Expander works is that it gives you a template. So I have all different templates here. So we have specific templates as to how to review ClinChecks, how to do prescription forms, how to give the charting instructions for refinements. But inside one of these templates is my ClinCheck adult points to review. So all I need to do is hit CC-adult, and what's going to happen is, let's pull up the full screen here. So I'm just going to go into, maybe it won't let me do this because this case is in retainers. Let me open this case up just as a demo case. And that should allow me now to have the text instruction box on the side. And even though I've actually finished this case, so spoiler alert, this is what the case looks like at the end compared to at the very beginning. So yeah, I guess if you guys have to jump off, you can see again, this can be done with Invisalign. But what I'm actually going to do then is this text box right here, I'm going to type in, and again, I teach all about this in our clearly aligned courses and in our clearly select community. So I'm just going to type in here, CC-adult. And boom, it is going to populate a checklist for me to review. So this will now allow me to go through and check off every single line item step by step to see if it was done properly. So let's go to ClinCheck number 1. Now, what I do every single time that I'm actually going through a ClinCheck is the first thing that I'm going to do is I'm just actually going to click here to remove the attachments. Right, my goal in giving you this information and us going through this case together is I want you to see exactly how I'm going to break down these cases step by step by step. There's some things I can't do because this case is finished, but I want you to see what we're planning on with this. And I want you to have essentially an algorithm, a pathway that you can follow so that if you are doing a root canal on a patient, you could be doing your ClinCheck right before that, and then you're jumping into the root canal, and then because you're going through step by step, as you finish the root canal, you're not coming back and looking at the exact same things again. You're able to come back and you're able to continue right on from where you left off. Because the number one problem with dentists who are doing cases and reviewing their ClinChecks, whether you're in New York or Florida or Texas or Vancouver or in Sydney, is you don't know what to look for. You're looking at everything all at once. You've got this massive problem, and you're essentially looking at this situation right now, and you're saying, I'm gonna fix this, right? Like this is what I'm gonna do. I need to fix this problem, right? I've got a crossbite going on in my premolars. I've got an open bite in my anteriors. I've got crowding in my lowers. I need to fix this. How do I do it? That's one very, very complicated answer because there's many different parts of this problem. But instead, if we break this down and we say, okay, let's take this from the very, very beginning. So we're on ClinCheck number 1. The first thing I'm going to do is review the technician's comments. Was there anything extremely important from the technicians? Well, let's go back to ClinCheck number 1 and let's read the comments. Okay, we programmed some active aligners to make some more movements happen, and then we've got passive. We programmed an anterior-posterior bite jump. There's software visualization. Some attachments are hitting the opposing arch, yada, yada, yada. These are all the instructions that I actually gave. Because I actually give a lot of instructions on my cases to change some of the velocities, like only allow half a degree of torque per aligner, or limit the amount of intrusion to 0.15 millimeters per aligner, how we do our expansion, how we overtreat. I'm not going to go through all of this right now. Again, I'll be lecturing in Australia in February. So I'll go through kind of all the components of prescription form when we're going through some of those courses, but also in our Clearly Select community, again, you can find out more of the information about, with all of our virtual courses, how we would approach the prescription form. But right now, today, we're living in the ClinCheck, not in the prescription form. So was there anything important that the technician said back? Honestly, no. There was nothing there that I actually care about. The next thing, and it's funny because, again, going internationally, like when I was listening to Jack and Lauren speak, as well as Rohit, they were discussing in their course how the first thing you have to look at is the bite set properly? And it's the exact same thing that I have on our checklist, even though we've developed this independently from each other. The first thing is the bite set properly? Because if the bite is not set properly, well, you're going to end up setting up the case to the wrong position. So I'll look at the central incisors, and maybe what I'll actually do is, instead of using the Align photos, let's use my clinic photos because the clinic photos are much better. So if we look at the midline of the upper to the lower, we're essentially halfway through the 3-1 is where the ClinCheck should be set up to. Yeah, halfway, perfect. Okay, if we go to the side view here, and we compare that with our side view, now the photos that were taken here aren't the best, but you can see how the canines are hitting canine on canine when we're at this angle, so it's the same view. On the other side, we can compare and say, try to mimic that same view. Do we find the same view that we can see here? Yep, pretty much the exact same view. So that's the first thing I look at. It's a very easy determination. So one of my staff, so at this point, I actually have a ClinCheck coordinator, right? When you're doing 400 cases a year, I'm not designing every single one from scratch myself. I'm reviewing everything exactly as shown here, step by step by step by step. But I actually have my ClinCheck coordinator who I've trained by taking these courses and sitting next to me while we design cases. She actually sets up the cases, and then I come in and review them with the same checklist and then click the accept button. And so we were doing a case together recently where I'm looking at it and I'm saying, well, Christy, this makes no sense. The bite's not set properly. Well, she had spent an hour and a half designing and planning this case with the bite set wrong, setting it up into a position where the patient starts off with a crossbite on the one side and a scissor bite on the other side. And she's moving the entire arch like this, right? Like this huge movement. Well, if that actually happens, we're going to completely mess up their occlusion. We better hope that doesn't happen because the bite's set wrong. So that's where the very first thing is that if the bite is set improperly, all I'm going to be doing on this ClinCheck right away is I will just immediately say to them, please redesign this ClinCheck to the photos, reset the bite to the photos, and I'll erase everything else because nothing else matters if that bite is set improperly. Okay, continuing on. We got a lot of info to go through, so let's keep this moving. Okay, so aligner basics. Is the bite set properly? Yes. The next thing, at the end of treatment. So at the end of treatment, do we have 4 passive aligners? So if you take nothing else from this lecture except for this one thing, it would be that you have the ability. Now, it depends on what product you're using, because if you're using a moderate product, you might not do this in Australia. But if you're using a comprehensive case, you have the ability to ask the technicians for 4 aligners at the end of treatment that don't do anything. They're blank. They just hang out and do nothing. And so what we're asking the technicians is for 4 passive aligners that don't do anything. They don't move the teeth, because we actually are going to bring this patient back in for their refinement at aligner 46. But then one of the worst experiences for patients is that you're on the very last tray and we're like, okay, great, you've done so well. And then you bring them back in a month later when their new trays have arrived and they've broken the trays. They're disgusting. It's a horrible experience for the patients. I think that a line should include as a baseline 4 passive aligners that do nothing. They're exactly the same tray, exact same tray, so that that patient changes out once per week until they get their new set of aligners in. That's what we're getting with these 4 passive aligners. So if you just specifically ask and say, please give me 4 passive aligners, then that's what we're seeing here at the end. But obviously, if you're using a light or a moderate package, then you may only have a certain number of aligners that you can get. So this is more for your comprehensive packages. Okay. So at this point, I'm going through my checklist, step by step by step. That's what I really care about at this point. Next is going to be the question of, are we correcting this case to class 1 occlusion? And if we are planning to correct this case to class 1 occlusion, are we actually accomplishing that? So we might have asked for ourselves for this case to correct class 1 occlusion, but are they actually doing it in the end? Right? Because if we've asked for it, do we want that? It might be that we don't want to correct a class 1 occlusion, or it could be that we do. And so let's go back up to the notes. So do I think that this is something that we will attempt to correct class 1 occlusion? Well, yes, I do. And on the top here, I'm going to click this bite and click at the end of active treatment, so that it's going to show me here what will happen if no changes to the anterior posterior occur. And if there is a little bite jump, quote unquote, this little bite jump here is simulating the anterior posterior change. So this is showing derotation of the teeth. So this is what we would expect to see if we do not have any changes to the anterior posterior. And then this is what it's saying, well, this is your ideal position where everything is perfectly interdigitated, intercuspated, class 1 occlusion. So in this situation here, I'm actually saying, okay, yeah, that looks reasonable here, that if we are here, this is without the use of any elastics for sequential distalization or a bite jump. And then this would be my anterior posterior correction if we were to do it. Now, when you look at the initial bite, this patient here has retroclined anterior teeth. It is quite possible in a case like this, where the central incisors are lingually positioned, that if you see a case like this, right, where they're tipped back, that as you actually procline the teeth and as you widen and develop the arch, it is super, super common in these cases, if the patient has TMD and they're saying, hey doc, I've got a clicking right now in my joint. Click, click, click. The next case is a TMD case. I'll show you it as well. And that's the one with the impacted canine. So you widen the arch, you fix the anterior position by fixing the torque. But if you do that, oftentimes the patient will come back and be like, hey doc, this is amazing, right? You've fixed my jaw issue. And you're like, oh wait, you had a jaw issue? I didn't even know that you had a clicking or that you were having pain. And they're like, no, you're amazing, you fixed it. Well, did we use elastics in their case even? No, no, maybe not. But then you look at the anterior posterior and you notice that the mandible has actually come forward. It kind of jumped forward, so to speak, right? Just like what this ClinCheck is showing right now. Is that from here to here, boom, that jump is a simulated position. It has nothing to do with the actual Invisalign aligners themselves. It just has to do with the fact that it's showing, hey, the aligners are going to do this, and then a little jump. That is the simulated jump showing them moving into a class 1 position, either from being a growing patient where you're modifying their growth with elastics or with the mandibular advancement feature or something else, or in a non-growing patient because they were constricted, because their mandible was forced backwards and their condyle was biting in a posterior position. When you widen the arch, you fix the torque, you fix the deep bite, the mandible will quite often come forward into a more class 1 position because their mandible was forced backwards. And so that is what this is simulating here with this jump. It's showing the changes that would occur to a class 1 occlusion. Now, how I will check to see how much anterior posterior change is occurring is I'm going to actually line up the lower first molar with the grid tool. And so we can line up this grid tool to see exactly how many millimeters, because each grid line is 1 millimeter. So how many millimeters of anterior posterior changes are happening? So if we look, we can see from this grid line right here, when we jump forward, it's jumped forward 1.7, let's call it 1.7 millimeters. On the other side, I'm kind of doing this one backwards here, but about 1.5. So because this is 1.5 and 1.7 millimeters of anterior posterior changes, do I think that it is realistic that this patient's jaw could reposition into a better spot as we widen and develop their arches if their condyle, if their mandible is constricted? Yes, up to 2 millimeters of anterior posterior repositioning can occur from arch development, expansion, proper torque and proclination, and deep bite correction. Those are the 3 key things to allowing the mandible to reposition. And let's actually even just take a look. I'm going to cheat here with this case. So if we look to their final position right here, yeah, she's pretty much biting in a class 1 occlusion. This is where she's at the end of treatment. And you're going to see that she's biting. There needs to be a bit of settling there, but she's biting in class 1 occlusion. So we do completely correct this class, her to class 1. But again, we'll break this down. We'll be going through all the other components here. Now, it does not mean that we're correcting every single case to class 1 occlusion. Now, why did I not back up the teeth here? Well, because she has a wisdom tooth here, and if you remember, the wisdom tooth on the other side is hanging out below the gum line. So we would have to take out our wisdom teeth if we were going to sequentially distalize the teeth, which is what you're going to see in the next case, the impacted canine one. Okay, so are we correcting a class 1 molar and canine? Very long answer to a short question. Yes. Are we actually in class 1 at the end of treatment? Yes, we are. Are we on the right side? Yes, we are. Great, fantastic. So I'm happy with that. We can erase this line. Curve of Spee. All right, let's speed this up a bit. Does she start off with a really significant curve of Spee, right? The curve of Spee is this curvature here. Well, it's not great. Could be worse, but it's not great. So we are going to intrude the anteriors. We're going to extrude that premolar and bring it up. So is it nice and flat at the end? It is. We have flattened the curve of Spee, but do we need to overcorrect it? Well, maybe slightly. We need to slightly overdo the deep bite correction. I would actually say probably not a lot because she's not starting off with a deep bite, but you could overdo the correction a little bit if you wanted to. The next thing, if expansion is occurring, So first of all, is expansion occurring? Are we developing this upper arch? Yeah, we are. Then the next thing here is, are we doing buccal root torque? Are we putting this in to the equation? What buccal root torque is referring to is that when we look at these premolar and first molar in particular, as we expand the arch, are we actually putting buccal root torque? Are we moving the roots towards the buccal? Now, the way that we can see this in this particular plan is by looking at the expansion and then seeing if the simulated gingiva is bulging out. Because right now, the crowns are tapering to the lingual. The roots are going more to the buccal, but we need the roots to also move. We need the crowns to move, but we need the roots to move as well. Another way you can evaluate this is just to look at the lingual aspect of the tooth and see, were we seeing more of the lingual surface of the tooth at the beginning, and then at the end, you should actually not be seeing as much of the lingual aspect of that tooth. These are ways that you can visually look at the tooth. The other way that you could actually see if there's buccal root torque, well, let's just go to this plan and click modify so we can see the 3D controls. The other way that you could tell whether there's buccal root torque is you can click on the tooth. And this section right here, buccal root torque, actually tells you, if you click on the root, that there is 2.1 degrees of buccal root torque that we're planning in. So if we want to put in more buccal root torque, well, now we can go ahead and see that, yes, we've increased this now to 10 degrees of buccal root torque. So this is another way that you can actually see how much buccal root torque is present, is from clicking in the 3D modifications to evaluate that. Okay, but in this situation then, go back to treatment plan number 1. Are we planning in buccal root torque? Is it actually occurring? Or is it planned? And the answer to that is yes. So again, we could click on the 3D controls and we could check it that way. But you can also just look at the tooth. Is there less of the lingual aspect or the palatal aspect at the end of treatment compared to the beginning? Or is there more of the buccal that you see from this occlusal view? And yes, there is more of the buccal. So the roots are moving towards the buccal. The next thing, what does the contact look like between our 6s and our 5s? So when we first start off, we need to derotate our 6s slightly, right? We want them to expand and to have a nice contact point between the 6s, the 5s, and the 7s. And so in this situation here, we have nice expansion and arch development. We have a nice contact at the end. So the buccal surfaces of these 6s, here to here, in this scenario, are parallel to one another. Right? And this checklist, what it's designed to do is just for us to take a look and say, hey, is there anything that's missing from this checklist? Now, again, this isn't to say that we always need to correct our molar position. Maybe this is a case where there is no TMD and there is no abfraction. And so we're going to leave the molars where they are and we're just going to focus on the anteriors. Well, that's totally fine if the patient understands and they're accepting that treatment plan. This isn't to say that every single time that we should be derotating our molars. This is just to be saying that in this scenario, are we evaluating our molars? Are we checking to at least see, like, well, what are we intending to do? And then what are we actually doing? And so in this case, I am intending to derotate, and they are. So check, it's done. Okay, what's next? Smile arc, how does it look? Okay, well, we can just go to, let's actually go back again to the patient's real photos. So we talked about this a little bit earlier already. But when we look at her smile, we can see that, okay, well, the lateral incisor should come down, the canine should come down, the upper central incisor should go up. I'm not scared of there being some gingiva when she's smiling. Gingiva is not a bad thing, as long as the teeth are proportional to the amount of gingiva showing. And so on our ClinCheck here, well, obviously we need to bring down our lateral incisors and our canine, and we need to intrude that central incisor. So at the end of treatment, if we were to do that, and we're also going to be getting some intrusion of the patient's premolar teeth here just by uprighting them, by expanding and uprighting, it's going to fill in the buccal corridor here, right? Because obviously in their first situation, in this situation, her buccal corridor is not full, right? We need to expand and arch develop in order to fill the buccal corridor. So let's just cheat for a second here. I'm going to jump ahead and actually show you guys what it looks like, spoiling my own case. So if we go ahead and bring down the canine and that lateral incisor, if we intrude that central incisor to line the gingiva, if we advance and expand and arch develop the premolar section here, well, this is what we look like in terms of our arch and in terms of our smile aesthetics. And then again, I'm spoiling things. But then after restorative treatment is done, to build back up the incisal edges, this is what we're looking at with our smile arc. So I'm okay with there being some gingiva. I'm not trying to get rid of that gingiva. Instead, when we go back to the initial position here for this patient, the goal is to say what needs to be leveled. And so are we looking to extrude all of the maxillary teeth? No. Are we looking to intrude all of the maxillary teeth? No, we're not trying to extrude or intrude all of them. All we're trying to do here is level the gingival margins of the central incisors by intruding that 1-1. Extrude the lateral incisor, extrude the canine. That's the considerations for my smile arc. Next, IPR for fragile tissues. Does this patient, when you look at her tissues, have a significant risk of recession? Well, the tissue type is a bit thinner. Doesn't look terrible though. Is the crowding significant? No, it's not. So do I think that she is at a high risk of recession? No, I don't. Now, again, I'm just going to jump out of order here because I'm going to give you a spoiler alert. Look at what happens. We start aligning these teeth. Tissue's getting a little bit more fragile here. And she gets recession. There is recession on this lower central right incisor. We didn't plan any IPR, nor did I think we had to plan any IPR. The reality is here is that if you want to ensure that you never have recession doing orthodontic treatments, I have a really good solution for you. Don't do orthodontics. Risks of recession are something that's going to happen on cases where you look at it, you evaluate it. We looked at this and we still said, I don't think that there's a huge risk of recession on that tooth. The tissue biotype is not terrible. There isn't already recession occurring, except for where she's in the abfraction or like hitting in the lingually constricted position. But it is a reality of orthodontic treatment that you will get patients with recession. It's kind of like you want to make sure that you never break a file doing root canals. Don't do root canals. You want to make sure that you never have bleeding gums when you're doing fillings. When you're putting in a sectional matrix or a Toffelmeyer or any other device to hold the filling in, well, if you want to make sure there's no bleeding ever, then don't do fillings. Right? It's just the reality of the situation is you can't control that. And so patients need to be aware of the informed risks. You know, when I just got my laser eye surgery done, which is kind of crazy because I'm not going to show you guys, it'd be kind of weird, but I can actually see, I kind of had a newer version of laser eye surgery done where they actually do it laparoscopically. So they don't cut the entire eye and then peel it back and then cut a piece out and then sew it back up again, or not sew it, but attach it back again. They actually make a little 2 mm incision and then they actually laparoscopically, the laser goes through that and it cuts the layer of tissue that needs to be removed out for the proper lens size. And then they take it out through that tiny 2 mm hole. Super, super trippy. But I can actually see when I pull my eyelids up, you can actually see these tiny little incisions still that they did with the laser. But one of the risks when they're literally going through things is like, you may have dry eyes forever. You could end up with 1 in 20,000 has significant neurological pain that you will feel burning in your eyes for the rest of your life. That is a risk. And moving on. You might get starbursting at nighttime when you're driving. You might all of a sudden see now all of a sudden street lights. It's going to be really hard for you to see, and you might not be able to drive at nighttime. The risk of that is not super high, but is it a risk? Yes. Is there anything that laser eye surgeon, ophthalmologist can do to stop that? Well, we're going to take our best precautions, but you're a good candidate. You qualify for this treatment. You don't have erosion of your corneas. You don't have anything major going on. So you're at a minimal risk, but it is a risk. You need to be aware of that. So it's the exact same thing with these patients. We'll try to do everything we can to minimize the risk of that recession. But in reality, the only way we can guarantee that you don't have recession would be we take out all your teeth. Because even if you don't do orthodontic treatment here, you can still get recession, right? Our upper premolars here, well, we had recession on these teeth before we even started because of the positioning of the teeth. And also, just fun note, if you look at this buccal frenum, the buccal frenum is also sometimes actually pulling, and that will cause recession as well on those premolar segments. So pay attention to that. But as we actually put those teeth into a better position, you see that the recession actually gets maybe a little bit better in the premolar section here, but in the anterior gets worse. Okay, so do we need IPR for fragile tissues? No, but is it going to bite us in the ass later? Yeah, it will. So maybe we should have, but I mean, there's a whole debate. You talk to some doctors about IPR, and it's like if you remove a millimeter of tooth structure, you're the devil. You're the worst, right? You shouldn't do that. You are causing airway issues. But what about when you have mad recession? Are we just going to let all these teeth fall out because of that? In my opinion, the answer is between the two, which is that it's about balance. It's about when it's appropriate, clinically speaking. So next thing we're going to look at is a Bolton discrepancy. Do we have a Bolton discrepancy? So if we click into this box here, Bolton, this is going to tell us if there's a mismatch between the arch sizes. And what this is essentially telling us, because it is less than 2 millimeters, is we do not have a Bolton discrepancy. So we do not need to do IPR because of a Bolton discrepancy. Everything does fit together properly. Next is, are there cancer midline shifts needed? Well, we had that slight camp, but we're going to be fixing it as we intrude the teeth. In terms of midline shifts, no, the midline was spot on. Whew. Okay, now you could go to a root canal at any point. You still have all these other things that you get to come back and look at. Hooray. Next. Okay, is there round tripping? So round tripping is essentially when you move the teeth one direction and then back the opposite direction for no reason. Or do these teeth move directly from point A to point B? Well, fortunately, everything is pretty much moving directly where it should go. And I don't have an example of round tripping on this case to show you. Again, in the courses, in my attachments and biomechanics course, I specifically show how round tripping occurs and how to remove it, but this case doesn't have any. It's actually good. So we don't have to do any removal of round tripping. The next thing is extrusion predictability. Do we have some teeth that are extruding that are going to be harder to extrude, that we need to pay more attention to? So is anything extruding a lot? And the answer to that is yes, absolutely. I would say teeth that we should pay attention to would be the 1-3, the 1-2, maybe the 2-2, and the 2-3. All of these teeth are extruding. Maybe not the 2-2, but the other teeth are. So we want to be aware of that, because with the extrusion, we need to look for some specific things, like, oh, and on the lower here too. This lower this lower premolar is extruding quite a bit. And so do we like the staging of how this extrusion is occurring? Do we like what's happening? Well, what I care about the most is that the number one reason that extrusion does not happen is due to friction. So let's go and take a look. Because did you know that in Align's default protocols, and this is pretty much the same for every aligner company, they actually allow the teeth to hit up against each other as they extrude. It will actually allow the teeth to slightly push through the pixels. So if you were looking at the pixels of the teeth as they're sliding past each other, it will actually allow the teeth to go through each other slightly. up to 0.09 millimeters or 0.09 millimeters. Now, this case that you're seeing right now has actually gone through a specific template. This has gone through the clearly select template. So even though this is plan number one, you notice that a lot of these things we're looking at right now, they're not bad. We're actually looking at the plan and it's like, oh, that was done right. Sweet. That was done right. Nice. That was done good. Like nothing we've really looked at so far has needed a lot of changes or adjustments, which is fantastic. And it's not usually that way. But that's because this plan actually went through the clearly select template, right? It went through a specific engine designed to specifically to look at these things. For example, right now, when these teeth are really crowded, it is actually specifically doing a different protocol. What it's doing is it's actually showing there being space around this canine tooth, right? So the first thing that actually happens here is instead of trying to extrude that tooth immediately, it's creating space. It's creating 0.5 millimeter of space, mesial and distal, to that canine. Because the number one reason that these canines don't track as we try to bring them down is that we try to immediately bring them down into the next tooth, into the premolar tooth. So instead, we're going to create space, and then these teeth will move down with space. Because what do we need to move teeth? Well, we need force, we need space, and we need time. So we've got this space created as the tooth moves down. And I will actually intentionally leave space when we have significant or challenging movements like this canine, the laterals, so that at the end of treatment, well, what happens if the space is created as designed? Well, you know what? Great. Because you know what cases are the easiest to close and to finish up or to do? Spacing. They're the easiest cases because the plastic grips intraproximally between the teeth. If there's all these gaps between your teeth, the plastic will grip in between them. Right? If you look at the number of advertisements that Smile Direct Club would do in North America when they were doing their mail-in DIY aligners, hooray. Every single case in their advertisements was a spacing case. Because spacing cases are so easy that even Smile Direct Club could do it. Right? Like spacing cases are super, super easy because the plastic can grip interproximally and there's no friction between the teeth. So if we want to ensure that these teeth move nicely past one another, well, you'd want to ensure that they're not bumping up, that they're not hitting against each other. And again, this is actually in treatment plan number one. So we do make some modifications and adjustments to this plan, but this is really good. Like this is making the case very consistent in terms of how things will move. But let's go ahead and take a look at our lower now. Right? Because this tooth is actually blocked out beneath the undercut of that other premolar. And if we look here, because we haven't planned any space and the algorithm didn't pick up on this, what's actually happening right now is that this tooth is pretty much moving directly through. Like, isn't this crazy? This tooth is trying to extrude and come up to start with here. It is literally going up right now through the neighboring tooth. So what I am evaluating here with this extrusion predictability on the side is that I'm happy with everything except this 3.5, but what I'd be telling the technicians here is create 0.5 millimeters of space mesial to the 3.5 before it extrudes. Do not close that space during the movements of the tooth. Okay, so all I'm telling the technicians here is, hey, crack open space here before you tried to extrude this tooth, so that you're not literally moving it right through the tooth because it's just gonna not track. Okay, so that's the first thing that we've noticed here on this particular plan that I'm like, yes, we really should change that. The next thing is black triangles. So at the end of treatment here, do we look interproximally between teeth and see black triangles? Well, yeah, we actually do. A number of these lower incisors are quite triangularly shaped. And so with those triangularly shaped teeth, it's something we should be aware of that we might need to come back and do some IPR between these teeth to adjust the shape of them. Now, we could jump in and do this IPR sooner in treatment, or we could wait and see what it looks like. We don't have to do it right away. Generally, in a younger female patient, I'm not going to do the IPR right away. I'm going to wait and see what it looks like at the end of this first batch of treatment. But be aware that there are black triangles. And so if we wanted to add in IPR, well, that's something we could do. And maybe I'll just go ahead and actually show you. I'll undo this. So black triangles. I'll just show you, we won't be able to modify this specific plan, but I'll modify the plan to show you here what things would look like if we were to place an IPR, how you do that. The next would be if IPR is occurring, are the contacts open? Right? Are the contacts derotated? Again, we don't have any IPR here, so it's not relevant. But I'll explain that when I do this black triangles. I'll explain more about doing the IPR when the contacts are derotated. And is the IPR occurring all at the same time? This is at intervals of 12, but this really should say at the same time. So my goal with IPR is to derotate the contacts and then do it when the contacts are actually derotated. So you're doing it between the interproximal surfaces, not doing it more on one tooth than the other. The next thing, you know what I hate? So now we get to finally turn on the attachments. Whew. Here's our attachments. You know what I hate? Is attachments showing up in the middle of treatment. There's nothing worse than halfway through treatment an attachment pops in. So are any attachments showing up right in the middle of treatment here? Well, the easiest way is click on the staging tab, and it will show you the triangles. The upside down triangle shows attachments going on. So if you see one in the middle of this section here, that means that, yes, there are attachments going on. Well, in this situation here, no, there's no triangles showing attachments going on. So we don't need to worry about there being an attachment showing up or changing in the middle of treatment. The next thing we're going to look at here is the number of trays appropriate. So this is a fairly complicated case. If this patient is changing out weekly, do I think their first batch of trays, realistically at 46 aligners, that's too many trays, too few trays? Well, we'll actually talk in just a moment about lingual attachments, because we're going to be treating this patient with those lingual attachments. But if they were changing weekly, do I think that this is a little bit long for treatment time frame? Maybe. Maybe we don't need to go quite so long. But when patients have lingual attachments, if you guys see me crying out of my right eye, it's just because it's very, very dry right now. So I'm actually doing most of this lecturing right now one-eyed. But if you see a patient who has lingual attachments, right? You're putting lingual attachments on. When they bite down, they're going to hit those lingual attachments. And so if they're biting down and they're hitting the lingual attachments, they're either going to break them off or they could actually chip their tooth. So patients in our practice who choose to do the attachments on the inside of their front teeth, if that's what they choose, they will actually eat with their aligners in. They eat with them in. When they finish eating, they'll take out their aligners, they'll brush their teeth, they'll brush their trays, and then they'll pop them back in again. But the difference is that patients who are eating with their aligners in actually change out their trays twice a week instead of once a week. So their treatment is going to happen much quicker. But I do plan that in this case, we will actually have more trays if they're eating with their aligners in. So if they were not eating with their aligners in, I'd probably be like, yeah, maybe 30 to 40 aligners is good. But if they're eating with their aligners in and they're changing out twice a week, then we're actually going to leave this at 46. This is fine. I think this number of trays is appropriate. Again, we'll cover a bit more of the lingual attachments in just a moment, because now we're going to go through the attachment section. Well, first, are there any pontics or eruption compensation? Is she missing any teeth? She's not. So we can get rid of that entire section. Whew. Now, here's the thing, guys, is that you look at this right now and you go, wow, this is a lot of info. You're telling me, Stephen, that you do this on every single case. Yes, I do. Now, the reality is that when I go through this, because I've been doing this same technique and standard of approach, it takes me all of 5 minutes to review every single one of these things and make the adjustments if they need adjustments, right? Because it's breaking down 100 or one really big decision about how do we treat this patient into 100 really little decisions. And it's like when I was, so where this is based off of is a checklist for flying a plane. I was working on my private pilot's license when my daughter was born. And so I was flying planes. And when I was flying planes, I would do a checklist. I'd walk around the plane and I would check over, is the plane in good working order? Like that's the ultimate question we have. Okay, well, how am I going to break that down? Are there is there air in the tires? Did the ailerons and the um, do the ailerons function? Are they properly working? Okay, go in the plane. Is there a fire extinguisher? Is the fire extinguisher, does it have pressure in it? Okay, do we pull the control pin out? Have I done that yet? Right? You go through this checklist of 100 different little things. And when I first was learning, it took me an hour just to look over the plane and I didn't even fly. Well, after I get better and I understand more what I'm looking for, it takes me 5 minutes to do my pre-flight checklist because I've done it enough times that it's breaking up those decisions into very minor, smaller decisions. So now we're at the point where we're looking at attachments. Okay, so with the attachments, the first section of the attachments is retention. By the way, you guys are doing great because we started off with 217 doctors on this call and we still have 214 an hour and 50 minutes in. Like, that's awesome. You guys are unreal. So, retention, replace if needed. So, do we need retention? Well, yes, we do. We have broken into 3 different categories. Deep bite retention. So, are we fixing a deep bite? We are. Is it a significant deep bite? No, it's not. But are we fixing a deep bite? Yes. Okay, so we need to have attachments on the premolar and first molar teeth, and potentially even the second molar if we're fixing a deep bite. Again, I'm not going to go through the attachments biomechanics of this fully right now. It's just, for right now, you can just memorize that if you're intruding lower anterior teeth, you need attachments on the lower premolars and molars. So do we have them? Yes, but I would really like to place one actually on the second molar too there. So all I'm going to do is I'm going to leave this and then we'll come back and I'll show you how to do this just on an example case in a moment. Next, expansion. Do we have attachments on all of the teeth that are expanding? Well, I do on everything except for that upper second molar. Does the second molar have buccal root torque? It does. And in this case here, it's actually the third molar. I'm not going to actually place anything on that third molar, but on this second molar, I do want to place an attachment, a horizontal attachment pulled out to its maximum thickness on that tooth. The next one, lateral incisors. Do I have attachments on my lateral incisors? Well, I do actually, for retentive purposes. I have it on the lingual side. But ideally, I might actually say, you know what? This lateral incisor and this canine tooth, the extrusion that this is requiring is pretty challenging. To actually place an attachment on the buccal here may make sense to ensure that it consistently moves. So I'm actually going to leave this here because, again, I'll show you what we did and I'll show you what I'm going to change here. So that's the upper lateral incisor is going to have things changed. The next one here would be root rotations and difficult movements. Okay. Are there specific difficult movements that are happening on teeth? Right? Significant rotation, significant root movement, significant extrusion that are not just the arch development and expansion. Well, yes, this lower premolar, this lower canine has a lot of rotation on it. Same thing with this lower, the 4-3 canine has a lot of rotation and root movement. So if I was just to write down which teeth are the ones that have difficult movements that we want to pay more attention to, I would say essentially it's the 1-2, it's the 2-2, it's the 2-3, it's the 3-5, it's the 3-3, it's the 4-3. Now you don't need to write all these down. This is just me explaining like these are the ones that have harder movements. Now you might click and say, well, let's go ahead and look at our tooth movement assessment. You guys might know of this tool. Movement assessment. And look at the black and the blue dots. But the reality is that most of our teeth are going to show up with blue and black dots because we're moving a lot of things. So I actually never use this tool because I find it does not actually help me here because most of the time everything is blue and black. Okay, but these are the teeth that have specific, more challenging movements. I'll come back to that in a minute. And then the next one will be, are there any crowns? So I don't really want to bond to crowns. There's no crowns, so we're okay. It's not that we can't bond to crowns, it's just it's definitely challenging bonding to crowns. Okay, so for modifications to this plan, then, how we again would make the modifications, let me go to here where we click modify, and now in the modifications, we can go ahead and place things specifically onto teeth. Again, unfortunately, it does not allow me to go back to the old plan to make the modification. It can only show me on this current plan. So I can place this attachment, I can bevel it. On the lower canines, I can go ahead and place a larger attachment. And I can make it longer. I can make it 4 millimeters. On our premolar here, you will notice that even with all my best intentions, it still actually has a bit of distal root tip to it. But I can orient this attachment however I like. I can change the size to make it bigger. We have control over that using our 3D modifications. And again, this is kind of unfair because you guys are getting to see the results of the case before we're actually done, but I can place attachments on the canine there to help with that extrusion. So we have control over all of that. So that's what I would do on my ClinCheck at this point is I would place those different attachments that I just showed you here to modify and make this more consistent. Because rather than using the little optimized rotation attachment, I'd much rather use a vertical attachment, like you see here, because if this movement doesn't fully express, whenever you're using a smaller optimized attachment, well, if you're doing that, if the movement doesn't fully happen, you are supposed to replace that attachment every single time. But here's the thing, it is so clinically inefficient with your chair time to remove attachments continuously and replace them with another one. It is such a waste of your time. So I would recommend don't do that. Instead, change this out for an attachment that's going to be much better. Change it out for an attachment that's a vertical attachment on that tooth. Right? Same thing with our canine. If we use a conventional attachment, or our laterals, I should say, to start with here. So this is the actual plan that I accept. So if I place an attachment that's a beveled attachment, so we blended that attachment up towards the gingiva to help rotate that tooth. Well, if this movement doesn't fully express, you know what's great? On our next round of trays is, you know what? This tooth didn't fully rotate. That 2-2. Who cares? I've got the right attachment on to finish moving that tooth. Same thing with the 1-2. I've got the correct attachment there. It doesn't actually affect us with chair time because what we will do in these circumstances, and again, I'm jumping ahead now, but at this point here, at the end of our first round of trays, we still have more movement to do. I still have more rotation on my laterals. I still have a little bit more extrusion. I have a bit of a posterior open bite. Again, we'll come to this guy here. I didn't treat this one the best, but you know what I don't have to do at this point? I do not have to change out any attachments. I can literally just give my patient their trays in the waiting room. I don't have to give this patient, bring them in for an appointment. Instead, they come into the practice. Here's your new trays. There you go. Try them in. Make sure they fit well. You're back off to the races. Right? We'll have another set of trays here. Treatment plan number 11. We still have a few more tweaks and adjustments to make. Right? We're still settling a bit of a posterior open bite. Well, no big deal. You don't need a new appointment to remove the attachments and replace them all. No, leave them in place because we tried to place the right attachments from the very, very beginning. So what are the major changes that I made then to this plan? Well, I do actually still maintain some lingual attachments in treatment plan 5, which the easiest way to do lingual attachments, I'm not going to go through all of that right now, but it's just to leave a horizontal attachment if there's space, or a vertical attachment if there's not space on each of the teeth. In this case here, because I wanted consistency in bringing these teeth down, I did utilize some buccal attachments as well. Now, My goal is I want to try and get as few attachments if this is what they choose to do. They get to choose buccal versus lingual attachments. They get a menu. You want them on the outside, you want them on the inside. But I tell them that if it's a really hard case and I need to bring teeth down and extrude them, sometimes I do need to have attachments still on the outside. So the major changes I've made, attachments went on the buccal of these canines and laterals, vertical attachments on our lower canines to help rotate. And then here's what I don't, I did tell them to create space. So look at the difference now at the space around that lower premolar before it moves up. But if I was to do this again on the premolar, what I would have done is I would have changed this attachment. I would have adjusted the attachment to be what you see here. A 5 mm attachment pulled to its maximum thickness. And I want you to think of turning a key, right? If I was to take my fingers right now and I was to turn this key, I'm going to grab that attachment and I'm going to turn it like I'm turning a car key, right? I'm pushing down right here and I'm pushing up on the gingival. So I'm pushing up on the gingival mesial and I'm pushing down on the occlusal distal. That is what will actually create a root tip movement. But because the attachment that I used is way too small and it's just a horizontal attachment, I wasn't able to generate mesial root tip. So if I did this all again, I would change this attachment to be a 45-degree attachment. We call that a sash, like a beauty queen sash on your body. My goal in showing you these cases is I want to show you the things I did well, and I want to show you the things I did not do well. I'm going to show it all to you, warts and all. Because that's the reality of what we did. So how does this all turn out then? I know we're already 2 hours into our webinar, our 3-hour webinar here. I was hoping that I'd actually finish up earlier so I could go to bed, but based on the next case too, I don't think that's going to happen. And you guys are troopers because you all worked practice, and if it's 8 p.m. right now for you, that's a long day. So those are the areas where I change the attachments. This is what I'd ask them for the 3-5 to ensure that there's space around it. If we wanted to do some black triangle modifications, well, what would we do? Well, on the bottom here, if we thought there's black triangles, we can click, we can add IPR. You can actually click on multiple of these at the same time by holding down the control button. And now add IPR for 5 contacts. And now we can ask the technicians, please do IPR when the contacts are fully derotated and do it all at the same time. So we're not doing it a million different times. That's how you'd place it in if you wanted it. But in this case, I haven't planned it. This is plan number 5, so this is the one we actually accept. So I did not actually plan in IPR there. But you know what's still left on our to-do before we can jump into the rest of this case? So we've got attachments on our, like we said, on the lower premolars. We want to place that attachment on the upper molars for the expansion. We wanted to make sure we had good attachments on our lateral incisors because they're always tricky teeth to move, and then our difficult tooth movements. And our laterals, that canine, the lower premolar. The last thing here is to evaluate the elastic situation. Right? We know that this patient is not growing. We know that elastics are not going to reposition their jaw from growth. Right? This patient, they're not growing. That's not why it's going to happen. But we know that sometimes the muscles can splint that patient into a poor position, right? If she has some clicking and the condyle is posteriorly positioned, if we can go ahead and help expand the arch, fix the deep bite, fix the proclination, the mandible may come forward on its own. But sometimes it doesn't. And in those cases where it doesn't, if we utilize class 2 elastics, so in this case here, we're going from the lower 6, the lower first molar on the buccal, to the lingual of that upper first premolar. They're running a class 2 orientation. That class 2 orientation of elastic, what it's going to do is 2 things. One is it's going to help pull forward the mandible. So if they're muscle splinted, it can overcome the muscle splinting. That's number 1. Number 2 is by running the elastics from the buccal of the lower to the lingual or the palatal of the upper, it is going to put in arch development and expansion. right? Anytime that you run an elastic from the buccal of the lower to the lingual of the upper, that's a crossbite component. That's an arch development aspect. Because the elastic, as you think of the elastic here, it's going to run between the occlusion then to this premolar. That will help with the arch development. Whereas if you run elastics from the buccal to the buccal, that buccal to the buccal, it actually is then going to constrict arches. So anytime you run elastics, buccal to buccal constricts arches. Whenever you run them buccal to lingual, from the lower on the buccal to the lingual in the upper, it will develop the arch. Okay, so the only other change that I really made here to this treatment plan is that later on in treatment, it's showing IPR occurring. In reality here, and we didn't actually do that IPR, but we're showing IPR to tighten up contacts. But in reality, I would say if I was showing this case again, I wouldn't do that because I don't need the IPR for bolt and discrepancy. We were essentially just doing it here to show the tightening of these contacts again. But what you're going to notice is this, is check out this canine. Before in our plan, this canine was coming down nicely and it had space around it. But now see how there's space, 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 and then we're trying to tighten up these contacts? And see how the teeth move through one another? Right? As these teeth are moving into one another, what's actually going to happen is you're going to notice this is going to stop tracking. It's not going to come down as far as we want it to because friction, right? What stops teeth from moving? Well, we know they only move when there's force, space, and time. So if there's friction between the teeth here, because we were using this as fake IPR to tighten up contacts later, well, yeah, this is going to stop tracking. Let's check it out. Where did that stop tracking? Pretty much right at that point, where we still need more extrusion. But it stopped tracking because, especially if you plan an IPR, but anytime the teeth are moving really tight to one another without space, they can stop tracking. So that's the other consideration. Okay, and we've expanded these teeth out of the crossbite. We have our buccal root torque. We looked at that earlier. We're lining up our gingival margins. So this is what we actually accepted. This is treatment plan number 5. This is what we actually accepted. So let's see what we actually accomplished then. So this is where we first started. And then this is where we're at after our first series of trays. Our gingival margins are good. If we look, we do have posterior open bite on both sides. This premolar is not extruded as much as we want. But the good thing is that they're actually biting in class 1. Look at that, right? They've repositioned their mandible because they were posteriorly constricted because of the narrow upper arch and because of the angulation of these incisors, how they were retroclined. We've brought down our lateral incisors on our canines. It's much better, but we still need more rotation on our laterals. But what did Stephen of the past do that was kind of smart to help Stephen in the future? Well, in the lateral incisor position, I actually left some space around them because the rotation was so significant. So now, finishing the rotation here and just closing up that space and bringing down that lateral a bit more is super easy. What did Stephen do because he's an idiot? Well, I had this IPR that we didn't end up doing for tightening contacts. And that canine didn't drop all the way down. And so we still need to bring this canine down more. And then I also didn't place the right attachment on this lower premolar for the root tip. In reality, I should change out this attachment. And that's the reason why throughout the rest of this treatment, even though I create more space around that tooth and I show mesial root tip, it doesn't actually help, right? I created the space. Anytime that you want a movement to be more consistent, create space around it. Right, so now you can see that again, we create space mesial of this, the canine. We're hitting a bit heavy on the palatal cusp, so we're putting in some more buccal root torque to settle the bite. We leave that space around our lateral incisors because again, This is where we're at then at the end of the second batch of trays. So let's show it on the actual photos. So here we are at the end of the second batch of trays. So again, we're getting close. We're much better with this premolar than where we first started, but we're not quite there yet. We're not quite there. So what we're going to do at this point here, where we still have a slight open bite. Oh, I'm one too far. Let's go back here to 11. So here's where we're at, right? We still are settling the bite. We're at the point though where we can do the restorative. So at this point in time, we can remove the attachments, do the restorative, and build back up those teeth. Do some basic settling movements. But what you're going to notice here then on our next plan is that we are not quite settled on these teeth, right? So we build up the central incisors. We're not quite settled on these teeth. What we will use in our practice that we do very frequently is we will use what we call active or temporary retainers. And these active or temporary retainers, what they are is essentially they're going to be trays that do not have any attachments on them, right? Because this is what the bite looks like right now. We're in a nice class 1. We need to settle the bite. So we'll tell the technicians remove all the attachments and just settle the bite. We tell the patients instead of wearing the trays all the time, they're only going to be wearing them now for call it 16 to 20 hours a day. And we're just going to let the bite settle through a combination of the movements themselves, as well as the fact that the trays will be out of the mouth and we're just letting gravity do its natural thing. We're letting those teeth just come down naturally on their own. And so this is where the patient is at this point. And then this is where the patient is 6 months later. Look at how the bite has settled just from this ClinCheck plan. Right? Because when you have a posterior open bite like this, often all you need is time. You just need some time for these teeth to come down and settle. And so in terms of this patient's situation then, this is where she's at. A beautiful smile arc. We fixed the curve of Spee. Things that I would look at and say I would like to have improved is I don't feel like the angulation of this premolar is as good as it could be. I mean, you can't really see it because her teeth are together, but she's not occluding as much on this premolar, the 1 or the 2-4 to the 3-5. There's a bit of space there. But in terms of the arch development, I think her arch development looks really good from where she first started. On the lowers, same thing. We do have that recession present. Right, all of her teeth are out of crossbite. And in terms of the abfraction situation from where we first started to where we're at now, things are significantly improved. You can even just see here again how the bite was more open, and then just giving it time, it's going to settle so that she's biting more evenly. And if you join Clearly Select, then you'll get access to all of the courses that are available. So there's 5 different courses: foundational systems, attachments biomechanics, diagnosis, development, and treatment planning, mixed dentition, and there's a mixed dentition part 2. And then right now we're finalizing getting the content for our teen. So unfortunately, it's a much longer topic conversation, but that's what I'm trying to do here, is to specifically show like clinical circumstances. And can we get 2 of these? Can we get templates for the actual ClinCheck itself? That's where, again, being a part of Clearly Select, which if you're interested in more information regarding Clearly Select, I don't know if it's in the chat already, but I'll just share this on my screen. With Clearly Select, this is essentially the information page that gives you information about what Clearly Select is. There's 2 different things that you're going to see. One here is essentially just the courses available that I was just talking about. So foundational systems, attachments biomechanics, all of the different courses. And there is packages to receive discounts and savings if you want to have multiple packages. So this is the specific for our, and this is all in Australian dollars as well. And then the second component here is if you want to be part of Clearly Select. So clearly select being essentially our educational community.